Good morning, everyone. So it's 9:40, so we'll get started as keep us on time. So I'm Craig Rackley from Duke University, and I've got the honor of moderating what I hope will be a fantastic session for you all. I will start with a little story and then introduce our folks, and then hopefully we'll have some time for questions at the end. So as I think back on our program, 15 years or so ago, we had a young, relatively small CF patient with predominant hypercapnic respiratory failure and a dual lumen upper body cannula that walked as a bridge to a transplant. And this was such huge news that it was publicized everywhere, and it was this major deal, and we wrote it up and sent it in, and it was groundbreaking. And over the last 15 years, I've sort of watched and said, you know, as I come to these, it's like, you know, it's just not possible to get that person up and awake. They need sedation, they're too weak, they're too sick, they're too whatever. And a few months ago, I was rounding in the ICU, and we're a couple of patients down from someone who's on ECMO with ARDS, and he gets up out of the bed with his bifemoral cannulas, walks around the unit with, you know, about 2 or 3 staff members, makes a second lap around the unit, comes back to his room. I go to step in and see him, and I look in, and he is sitting on the toilet having a bowel movement with bifemoral cannulas after he just walked 2 laps around the unit. And I thought to myself, oh my gosh, literally, we, you know, this guy, look at how far we've come, look at what we've done. And there have been so many steps along the way. This has been such a multidisciplinary approach, and I think you have sort of a great benefit today. You've got Hussein Kanji, who's a cardiac surgeon from Vancouver, who's going to tell you why this ought to be the standard of care that all of us are doing. We've got Bernadette Elliott here, who's a nurse from San Antonio at the military hospital, where they've done incredible work, waking these folks up, taking their tubes out, getting them walking, getting them doing calisthenics, everything. So she's going to tell you that perspective and how to do it safely. And then Desiree Bonadonna is a perfusionist from Duke who's taught me pretty much everything I know about ECMO and has helped us throughout all of this process, and is going to talk to you about pediatrics. Daryl Abrams from a sort of up-and-coming program in New York is going to tell us a little bit about doing this in patients on VA ECMO. They will just follow each other, and hopefully that gives us a few more minutes at the end, because I know you're going to have questions about how each of these folks have done this, and how do you deal with this situation, how do you deal with that situation. So without any further delay, Hussein, please join me up here.
Well, thanks so much for the introduction and starting the process of talking about this. And you're absolutely right. We come to these meetings and we hear these magnificent and wonderful stories about getting patients up. And I think somebody quoted, "Gosh, I have my patient playing basketball on ECMO," right? And we're excited by the thought and the notion of extubating and mobilizing and getting our patients up and doing these sorts of things. But we're also often dissuaded by the fact that we can't get there often enough, and we try very hard. So I'd like to say, you know, as a disclaimer to this talk, be very thoughtful, very, you know, optimistic about the thought, but it's about the process and the thought of getting you there and getting our patients there, but often is a very difficult process. And so I'll talk a little bit about how we get our patients to that state, but at the same time, just the process of actually going through that, lessening the sedation, working and helping our patients to get to that place, even though you cannot often get them extubated or mobilized, is fruitful enough and has a lot of power. So with that, I have to do this in 8 minutes or less, which sounds a bit ridiculous, but we're going to try as best we can, and I think the discussion of the thought process is going to be, I think, the most beneficial part of this. So why don't we often mobilize and move our patients and try to get them? I think it's very fear-based. You remember, if some of you have started these these programs, ECMO in of itself, it was very scary having somebody on these large tubes and these cannulas and being there. Just having a patient on ECMO is very scary, let alone actually moving them, actually turning them, actually proning them. So we'll talk about the fear and how to conquer that fear. What is the standard of care? Really, there isn't one. And people say, gosh, we need more and more and more research. Well, I will actually tell you, my belief is that we have the research that proves enough that mobilization in these patients is quite effective enough. So yeah, we can have more research to understand the phenotype, the dosage, these sorts of things, but we know this is a very, very beneficial, effective thing to do for our patients and has huge benefit. What is the process? I'm going to talk and make a few motherhood statements around that and really taking us back to basics, what we know about these patients, specifically in the ARDS population, individualized process, looking at the barriers of what and how, and then when not to do this. I don't have any disclosures. I wish I did. It would I would be a lot more important than I am right now. But so what do we know? What do we do in the ICU? We try to help. We try to keep our patients alive. And again, these motherhood statements, one of them I'll make today is that I think we as a community, as a critical care community, don't do this well enough. We don't need to keep patients alive. We need to keep patients alive and well. The quality of life piece, I think we miss lots. 6 months, 1 year, what is it? What is the metric of what we are actually trying to achieve? And that's why physiotherapy, I think, mobilization is so important, because it's not good enough to keep people alive anymore. It never has been, I think. We need to keep people well, give them that quality of life. If we have, and I keep somebody alive, but I have them in a debilitated state for the rest of their lives, that is not what I want to achieve as a physician, and I don't think that's what we are. And we need to be asking ourselves this question: are we doing well to the patient? And part of that is actually this part of care, which is actually mobilization, moving patient. We should be thinking about frailty scores as patients come into the unit and leave the unit. How are they when they come in? And what is their risk of moving out? So, things like this, I think, and I believe, and we're starting to, but don't do well enough, is looking at frailty scores and understanding how these patients are going to sustain and progress as they leave the unit. I always tell the fellows and residents, I said, what is it? What are we doing? It's a bridge to something. Okay, so when we put somebody on, we must think about who they are, how they're getting there, and what is the bridge? What is your end? And it is, a lot of patients, and we did a study with Giles, and it said, look, patients leave the unit, and believe it or not, even ARDS patients on ECMO actually go back to work. It's not good enough, again, to have ECMO as a bridge to something, survival. It's getting off that bridge. And again, when you get off the bridge and you live your life, what sort of quality are you going to actually have? We know that in the ICU there is acquired weakness. And in fact, we know that ECMO patients have even a more profound effect of ICU-acquired weakness. In the study, we can see that there is a reduction of muscle mass that is quite profound in their ECMO patients. And that's going to result in further debilitation later on as they leave the ICU. I'd ask you to look at this. It's expert consensus here, done by the group, and looking at the effect of mobilization in our critically ill patients. Again, the data is there. We know that these patients, in fact, need this, and it improves their outcomes overall. Dan and his group, as well as someone you're going to hear from a little later, our colleagues have published this, a very, very simple approach to how do we actually mobilize patients. So this is a very simple approach, a nice multidisciplinary approach to mobilizing the patient and being able to actually move them, and how to actually approach this for the patient in a patient-centric approach. We know that it helps delirium, more ventilator-free days, improved functional status, and overall helps the outcomes. So again, why don't we do it? Because we're scared, I think, often. Don't be scared. Think about the process and how you can actually mobilize these patients effectively. So when you look at this, I stole this slide from Bavish and the Mayo Group, looking at the physiologic reserve, and ECMO is just a piece of the puzzle. We often get paralyzed by ECMO, but we shouldn't. It's like CRT. It's another piece of the puzzle. in the care of these patients. So think about that as you start to mobilize these patients, start to approach these patients. It's another piece of the puzzle. You should not be paralyzed by ECMO, but actually use it to your advantage, and I'll talk about that in just a second. So a lot of this I'm going to be talking about. We published with a great colleague of mine, Simi, who's here in the crowd, and Bav, looking at simulation, how to move these patients, how to understand how to move these patients, and some of it is really sedation-based. We must always think about reducing and tempering the sedation very early on. We need to be thinking about this the minute they get put on ECMO. I said, what is the number one problem in our problem list of being on ECMO? Getting them off ECMO, okay? And part of that is actually thinking about how to get them off ECMO. This is part of the study. This is our group here mobilizing these patients. Again, yeah, this great picture of getting somebody up and about, but this doesn't happen often. But how should it happen? And one of the things I realized in my ignorance was with mobilization and physiotherapy are two very different things. Mobilization is moving the patient. Physiotherapy is actually actively engaging and doing the care that is necessary to improve the functional outcome of these patients, which is what our people do, which our physiotherapists are there at the bedside helping with that. Again, the fear and inexperience are some of the barriers that actually stop. And I think applying simulation, thinking about that process, understanding it, working with your multidisciplinary team to understand those barriers, and applying not only mobilization, but physiotherapy practices to your patients, I think very, very important. What is the thing as well that really limits us? It's physiologic reserve. All our patients have incredible physiologic dependency on ECMO, and we have to understand what those physiologic reserve is. So you look here, gosh, even resting, you look at the heart rate changes and the VO2 sort of demands from physical therapy and resting, you're going to be challenging these patients. So what do you apply? Gosh, I can put up this scoring. It's called the SAFER HD. It's in the chapter, looking at all the different things that could limit them and to think about what may limit or challenge the ability to mobilize and apply the physiotherapy to these patients. But I would challenge you to say you have to understand their physiologic reserve. You have to understand what is actually how these patients are dependent on the machine and the extracorporeal parts. You can look at these exclusion criteria. You will have these slides eventually, and gosh, do they have the myocardial infarction? Do they have inotropes? How much or how dependent on the inotropes do they need to be to limit them? I don't have the answer to that. There is no gold standard. They're on this much levo or this much epi. What you need to do is you need to think about how much physiologic reserve they in fact have and how much they can engage in this. So, but you need to think about this. You need to think about this the minute you get put on ECMO. You need to think about moving that patient. What can you do? Well, if you can't get them out of bed, there's a great paper that explains neuromuscular electrical stimulation. I haven't done this, but it's something I want to contemplate with our patients. And it's shown to have actually very profound and effective results in patients who can't get out of bed. Our cycling, our strength training, and think about that theory. This is my colleague here, Sunny, has published a nice paper on sort of VV ECMO, and I will challenge you to actually think about, and we do this from time to time, is in fact limiting or stopping decannulation of our patients to actually facilitate physiotherapy. So they can come off for their lungs, but we keep them on to help mobilize and actually improve their mobilization and physiotherapy thereafter by function of the ECMO, because we are providing that physiologic reserve that they don't have with their native lung function. I think this is a very, very interesting thought, something I'll challenge you with, something that we do from time to time to facilitate this part of the process. And the last thing is think about what you're doing, measure what you're doing. So we've started to do this is using the CPAC score and looking at our patients and whom are actually improving over time. So are we having an effect? And in fact, we have shown and we're learning that some of these patients actually start to deteriorate, and those who deteriorate from a physiologic or a physical therapy standpoint or strength standpoint actually do worse. So it's actually a marker or harbinger for poor outcome as we move forward. And recognizing that these patients are actually deteriorating or getting weaker as we measure their outcomes, we know to intervene in some way. It could be sepsis, it could be something else, but recognizing that these patients actually are doing more poorly because we're measuring and we're looking at the effect of our outcomes. So I don't have any conclusions, but I just have some thoughts. The assessment should be, and the thought should be, within 24 hours of putting them on ECMO. I want everyone in this room to think about mobilizing their patients, whether they do or they don't. What is the phenotype? Who does better? What is the dosage? We still don't know. But I think the process of actually thinking about this and starting it is the most important part. Conquer the fear, use simulation, talk about this, understand, and make this a practice. I would suggest that this is as important as anything else, antibiotic therapy or whatever it may be. This is going to have major impact. It's going to be a function of your team, your interdisciplinary team, who are going to be your champions to actually make this happen. Find one, find many, and continue to make this the culture in your unit. There really are no absolute contraindications, but there are those that we need to think about, and I would suggest it's physiologic reserve. Again, as you grow and assess, look at, use your scores, we use that CPACs, and understand how your patients are moving forward, and then, let that define the now. So thank you very much, and I hope we'll have time for questions after.
Good morning. I am Bernadette Elliott. I am a nurse from the Brooke Army Medical Center program, and I am honored to present these slides for Karen and Reagan, who are our awesome PTs that have developed our program. This has definitely been a program that has broken all silos and brought in all of our disciplines to do this very well. And we've done that under our medical director, Phil Mason. So if any of you have heard anything about Phil's approach to sedation, it's not sedation holidays. Like, you have to work really hard to get sedation if you're an ECMO patient. I also don't have any disclosures, but I do have to say that this is not an official representation of anything for the Department of Defense or the Defense Healthcare Agency. Why is mobility important? Well, we all know that critical illness is terrible for our musculoskeletal systems and our skin. And we know that if we are immobile, we end up staying in the ICU longer and in the hospital, therefore. And so we practice the ABCDE bundle there in our program. We definitely see a prolonged stay for patients that we get late referrals to ECMO on, because a lot of the places call us, their patient has been intubated and sedated for 10 days, 14 days, and we are now, if it's post-COVID, we're really, really liberal with our selection. We've taken patients that a lot of people probably wouldn't, and we've seen some good results because we do wake them up and get them moving as soon as we are able to get to them. This is kind of the early mobility protocols that our PTs implement for us. They do get an order placed within 48 hours of admission. It is part of our bundle set, and we ended up writing it for 48 hours because sometimes we do bring patients in, early morning Saturday or whatever, and they're not always there. But the PT techs do come around and help us, for those of us that are blessed to be working on the weekend with these patients, and they'll do the formal evaluation and tell us what we're going to be doing later in the week when they get there. First, they do their safety screen and then start writing on their mobility protocol. Again, risk factors, benzos, really hard to get in my facility, the duration of sedation, fear, stress, and delirium. I will say that this has really been a change culture. Me as an ICU nurse, I loved intubated, sedated, and paralyzed. Like, that was my pre-ECMO practice. That was who I wanted to take care of. And I joke and say that that's why we were all there. We loved controlling the whole world. And so my team has really seen a change. Initially, we went from primary care model to a drawing straws model because working with these awake, anxious patients was really, really taxing on my team. But now that we've seen a few really awesome wins and we see what we can do by waking these patients up, everybody's understanding that we really need to look beyond just the care of their body, and we need to take care of them as well. Here's our ABCD bundle. You'll see down here in the corner at the bottom, you have to work really hard to not have to get out of bed in my program. If we're escalating pressors and you've been stabilized on that dose for 2 hours, you're probably gonna have to do something. If you have an open abdomen or a skin flap, we might let you do stuff in the bed, but it's pretty iffy. Like, it's getting really hard to get out of PT. We definitely have kept patients on to meet a physical therapy goal before we've decannulated them for that very reason that he was discussing earlier, because they really needed to be able to be functional whenever they were going to go home, and that was discussed with the patient, and they got to be part of those goals, and they were so proud when they were able to achieve that. Like I said, our PTs are so involved. They actually attend our daily rounds for each ECMO patient. They really get to discuss the plan, and we do pair our ECMO patients sometimes as high as 4 patients to 1 specialist, and so timing of PT is a priority for us. We will move around, CTs if it's not an emergent situation or something, to allow for physical therapy, or sometimes even integrate it into, for instance, getting a patient to stand bedside and we'll go down in a wheelchair or something like that, just to integrate and make sure they get some sort of physical therapy each day. And then their goals are assessed daily, and we really share all of their achievements and successes with the whole team. So when people are just walking through and my specialists poke their head in, hey man, I heard you did really great today walking. We've even had patients walking in the hallway, like issuing challenges to another patient that's on ECMO there because they've seen them walking also. So it's really completely changed the culture of our ICU. If you can't get out of bed, then what do? This patient happens to be a quadriplegic. He was a fall from a 5th story of a building that was under construction, but that did not get him out of it. He definitely was trained up on the tilt table, and this took I want to say it took us almost 2 weeks to be able to get him in the upright position because he was just orthostatic, and that was just his mechanism of injury and the level of deconditioning. And he did get to partake in the neuromuscular electrical stim. Another patient there, he's also a quad, and you can see that, CRRT there on the left, and, every single level of support represented there, and yet they are still tilting, helping them to be able to tolerate the weight bearing again so that they can maximize their function whenever they get into the wheelchair. And these are some of our physical therapists' favorite toys and tools. And when we opened our program, we really tried to utilize what they were already had purchased and were familiar with in our program. And they have therefore started to expand their asks of their purchases of equipment because it's really, driven up the enthusiasm of everybody. And they're so proud of what we're doing in our center. And so we've purchased some really cool stuff. If logistics is a barrier, we still definitely do a lot of edge of bed activities. We talked about it needing about usually 3 to 4 people, depending on your patient's baseline condition, to do stuff. Just because we're short-staffed, it doesn't mean that we're not going to do PT. We just might not go out of the room or go as far. Of course, ambulation is usually our goal because that enables us to get them interactive with the world and with their family a little bit more, and it kind of gives them a better sense of life after ECMO. With that, I would like to say thank you so much for this opportunity. If anybody would like to contact me, I'd be happy to put you in touch with our experts. I definitely got to be a part of the team and have many a day just sat there for that really not so fun day of waking up from a lot of sedation. And that may be what we're going to have to tolerate, is just one really bad day of waking up in order to start getting our patients up and going. Thank you.
Hi, everyone. Thank you for having me. My name is Darrell Abrams. I'm from Columbia University. And some of what I'll be talking about today is what do we do with the VA patient? Is that a contraindication? Is that something that is kind of an emerging field for mobilization? Is it about the cannulation? Is it about the patients? So I also, unfortunately, much like Hussein, have no disclosures, but I'm open. So, you know, a little bit of this was already covered in terms of just the rationale for mobilizing patients. This is not a new concept, obviously. This is why we're all here talking about this. We know from a lot of literature that early mobilization is certainly feasible and benefits those who are critically ill in general. Forget about ECMO for a second. It can be done safely, particularly in those with respiratory failure. There's a lot of literature, obviously, on mobilizing patients on invasive mechanical ventilation. And we know that ECMO patients have some of the most severe forms of cardiopulmonary failure. So it lends itself to, are these patients likewise able to benefit from mobilization? And they're certainly, at the same time, at the greatest risk, probably because of the severity of their underlying illness, for immobility, weakness, and subsequent debility. But I caution you, and this is why it's not just one big bucket, there's a lot of different types of ECMO patients, right? We're not just saying they're critically ill, we're not just saying they have respiratory failure, cardiac failure. ECMO patients come with a lot of different flavors and cannulation strategy, configurations, and underlying disease processes. So there's a lot of implications with that. Not only is it feasible, but is it doable? Feasible and doable, but is it safe? And is there a true benefit to doing it in all ECMO patients or only in some ECMO patients? And a lot of that literature is still yet to be elucidated, but we have a little bit of information so far. So in that same vein, that ECMO patients aren't all created equally. You've got the bridge to transplant patients, and even within that, we've got patients who are with end-stage respiratory failure, predominantly on VV ECMO, but you'll see a lot of patients on VA if they have concomitant RV failure. There's a lot of implications there in terms of the cannulation strategy, how well they're supported. And likewise, the end-stage cardiac failure with VA ECMO, and oftentimes in those scenarios, because of venting of the left ventricle, from overdistension from VA or from their underlying disease process, they may have other mechanical support. So it's not just necessarily about mobilizing an ECMO patient, it might be about mobilizing an ECMO patient who also has a lot of other support systems in place. But this is the population I think we focus a lot on in terms of mobilization because of the priority in a lot of centers that they're not going to remain a transplant candidate if they're bedbound and immobilized for too long. So very early on, and certainly as a priority for patients who are candidates for ECMO, is ECMO going to facilitate mobilization that they weren't able to do without it? Or at the very least, is it going to be able to maintain the amount of mobilization, physical therapy, and conditioning that gets them to transplant? Because if they can't achieve that with ECMO, then they're probably not going to stay on a transplant list for very long, and then you're going to end up with a bridge to nowhere. But these are certainly, I have to say, of the bridge to transplant, bridge to recovery, the transplant patients are of the higher priority for that reason alone. We don't want patients to be debilitated who are bridge to recovery, but transplant, their only out is transplant. So we have to make sure that they maintain candidacy throughout their ECMO run. And that's in contrast to the bridge to recovery, where I think even though it's encouraging and we should all be very proactive about trying to mobilize who we can, I don't think the data is robust that bridge to recovery patients necessarily are going to derive enormous benefit from early mobilization, even especially in that early phase where they're so super sick. And I don't disagree with Hussein and Bernadette. I think when the patients that we can identify and that can be mobilized and minimizing sedation and doing those things early are of great priority if it's possible. But there's likewise many patients who are just so sick when they first go on from such severe ARDS or severe cardiac failure that they may not early be able to achieve that kind of mobility to the same degree that we're trying to cherry pick the transplant patients who are already active and we're trying to maintain activity, or who we think with physiologic support can become active when they otherwise would just be bedbound while waiting for transplant. So as far as feasibility with mobilization of VA, a lot of what I think was discussed so far was really focusing a little bit more on the VV population. But in terms of mobilizing with VA, there's a few papers out there that have shown certainly feasibility. So the group out of Maryland published a few years ago on their success with a mixed population VV, VA, bridge to recovery, bridge to transplant. They did have some mobilization of femoral VA, and that was kind of one of the earlier reports of people being able to get out of bed and walk. The numbers ultimately, when you boil it down, were not huge, but it was the first steps, and it was really quite impressive with very low complication rates and a decent number of PT sessions across over 160 patients. And then a little bit more recently out of Germany, there was a population of 43 patients who were mobilized out of 115 they had on ECMO. And there were quite a few who were on VA ECMO, and a lot of those patients were mobilized. There was 93%, I think, of the sessions on VA were mobilized, but again, ambulation was a real limitation. They were able to stand, they were able to transfer to a chair, but we weren't talking about prolonged ambulatory sessions. And also, again, though, very rare adverse events. And I think we've seen that over and over, that centers that are accustomed to doing early mobilization and accustomed to growing that program to include ECMO patients, it can be done quite safely. It does take a multidisciplinary team, interprofessional team, but it's not, I don't think safety, when you're comfortable with it and you have the right support system in place, safety becomes much less of an issue. It's obviously a big issue when you're first learning, but once you're accustomed to it, I think it's quite feasible. And then speaking a bit to our own program and our experience, we got a little bit more into the weeds because we have a rather large early mobilization program that started about the same time our ECMO program really became formalized. So the two really dovetailed together, and we were mobilizing patients relatively early in our formalized ECMO program. And over the years, since we accumulated so many patients, we wanted to get a sense, are there predictors of more active physical therapy, getting patients out of bed, not just doing stuff in bed on ECMO, but really getting them to sit at the edge of the bed, stand, and walk? And are there ways that we can predict which patients are going to be the best candidates to do that, at least to the extent that we're comfortable mobilizing patients? So this is our experience spanning really the duration of our ECMO and mobilization program since 2009 up through the beginning of 2020, so just pre-COVID. We had 177 patients. The vast majority were bridge to transplant that were mobilized, but it's not a trivial number of bridge to recovery patients. And because of the way we cohort our ECMO patients, at least for respiratory failure in our medical ICU, these really all encompassed patients with some form of respiratory failure, be it ARDS as the predominant bridge to recovery or bridge to transplant. But there was quite a fair number of patients who had concomitant RV failure as a consequence of their pulmonary hypertension from their underlying lung disease, or patients who were group 1 PH. So there was a mixed population which really encompassed cardiopulmonary failure. And as a consequence, there were quite a few VA patients in the population. So there were we had performed 2,700 physical therapy sessions across those 177 patients. Again, you see that the very skewed, the vast majority of our mobilization sessions were in the bridge to transplant population. But there were about 8 sessions done per patient. You can imagine those bridge to transplant, longer runs, more opportunities for early mobilization. Bridge to recovery, they may not have been awake for as long and had the same opportunities for mobilization. But a high number, more than half of our mobilization sessions occurred with VA. And also, the large majority of our PT sessions achieved at least standing or greater in the ICU mobility scale. And of the ambulatory patients, that accounted for 61% of the total patients were ambulatory at some point in their run. Again, mostly bridge to transplant, but quite a few bridge to recovery. Some of those were part of our pilot study on supporting COPD exacerbations with ECMO to facilitate extubation and mobilization. So that accounted for 5 of those bridge to recovery. But there were other patients as bridge to recovery, including ARDS, that we were able to wake up and ambulate. You can see the types of sessions we did, over almost 1,300 sessions with a pretty decent average walk distance at maximum walking. And then to kind of bring it back around to VA and the cannulation strategies, 66 of the patients, so about a third of the patients had at least one femoral cannula in place. And of those 700 femoral sessions, or sessions where there was a femoral cannula in place, there were 180 sessions with an arterial femoral cannula. So femoral cannulation alone is certainly not a barrier, and don't foresee an arterial cannula in the groin as necessarily being a barrier to mobilization. The way our program kind of evolved, we started early on with a lot of upper body cannulation approaches for VV, as many programs probably adopted when they're thinking about mobilization, and for bridge to transplant. But then we'd start having some 2-site setups for VV for bridge to transplant, and certainly most of our bridge to recovery were 2-site VV. And then it evolved that we had comfort with mobilizing the femoral venous cannulas, and by extension started getting more comfortable with mobilizing femoral arterial cannulas that were well secured, just sutures, no real exciting other devices to secure it to the leg. And it kind of grew from there that we became more comfortable. And certainly those patients who might need VA and need it urgently and need to go on femoral VA to start, we didn't want that to necessarily be a barrier if we could keep them mobilized if they were bridged to transplant in particular. And then that kind of precluded the need necessarily to convert to an upper body just for the sake of mobilization. Because if we were able to do it with femoral VA, if that was the one thing that really, as long as they were well supported, well, then we didn't necessarily have to have that second step to going to something upper body or central because we were able to keep them mobilized and fit. And so, even of the ambulatory sessions, we had 250 sessions, of which about a fifth of them had femoral arterial cannulation. So then we wanted to look at, like I mentioned before, what were some of the predictors, ways that we could envision, who are the patients most likely to mobilize, and not just mobilize in bed, but actually get out of bed and do out-of-bed physical therapy. So not unexpectedly, since our intention to start with was, in particular, our priority was on the bridge to transplant patients, being BTT was a positive factor for getting out of bed and achieving an ICU mobility score of at least standing. And likewise, being on VV. And this is just from the evolution of our program, right? This was all retrospective analyses. But those that, even though we mobilized so much femoral, arterial, and venous cannulation configurations, femoral cannulation still, relative to an upper body cannulation approach, had decreased odds of getting out of bed. And likewise, having patients who are still stuck on the ventilator despite ECMO support, because despite the amount of support they were receiving from the device, they still weren't able to be liberated from the ventilator. That was a hindrance to getting out of bed. Not because we can't mobilize ventilators, but because now you're mobilizing a ventilator and a circuit, and it just speaks to the fact that these patients seem to be sicker and need more support than just ECMO alone. So there's a lot of different strategies. We've alluded to some of the configuration strategies. The most common that everyone's used to, from certainly an urgent cannulation approach, is FEM-VA. But just showing in that picture some of the problems you encounter, especially thinking about our population with a lot of RV failure, their LV is usually pretty well preserved. And so if they've got RV failure and intrinsic lung disease and impaired intrinsic gas exchange, that kind of sets you up for that differential oxygenation, dual circulation. So that may not be ideal from a support standpoint alone, but also, if you're a center that's not used to mobilizing femoral cannulation, maybe this is going to be a hindrance to you getting patients out of bed if you're just not comfortable yet. So there's other approaches. There's upper body configurations you guys are all probably used to seeing. We started initially with grafting to the subclavian or axillary artery as an upper body. We used to call this the sport model. As we've moved on, some patients had very small subclavian and axillary targets, so it was hard to graft to there. As an alternative, we went a little more central. We call it the central sport, to the brachiocephalic artery as a way of still providing upper body. But you can imagine none of these are emergent cannulations. These all have to be planned and maybe staged from a femoral up to an upper body, since this requires cut down or mini sternotomy or mini thoracotomy. But as we've moved on to other configurations, this is where, getting into the other population, which I haven't really addressed as much, is the cardiac failure population. And for those that, like I mentioned before, they may be on VA, but also have a balloon pump or also have an Impella, and now have multiple devices, a couple of which are much more tenuous from a positional standpoint that you don't necessarily want to mobilize the patient. So some of the more novel strategies that our center have incorporated, with Koji Takeda taking the lead, is what we call the KVAD. So basically, it's drainage from the IVC, and then that same kind of grafted reinfusion to the subclavian or the axillary artery. But you can also Y in LV venting to that drainage cannula. So now you're draining from the IVC from the right side, but you're also venting the left ventricle and reinfusing to the upper body, to the subclavian or axillary. And then that can be converted to more of a straight up VAD if you remove the IVC drainage and just have LVAD drainage and upper body reinfusion. So this is just another strategy to try to mobilize these cardiogenic shock patients who are bridge to VAD or bridge to transplant. But the principle behind it's still the same. Are they adequately supported? Do they have enough physiologic support that they can actually do things, to Hussein's point, about what their demand is? And they have a lot more demand, some of these patients, and are we able to support them with enough blood flow and gas exchange? And then there's the central, even more central upper body cannulation configurations where you have IJ or direct RA drainage and direct aortic reinfusion as an alternative, which really minimizes that dual circulation, but again, a more invasive. But once you have it and they're closed, we've been very successful in mobilizing these central cannulation strategies. And we've done it more in the MICU for RV failure, like I've said, but certainly can be translated with enough support to the cardiogenic shock patients or the bridge to heart transplant patients. So as far as considerations for mobilizing VA, First thing, is your program comfortable with doing mobilization at all? And if so, are they comfortable mobilizing ECMO patients, broadly speaking? Before we talk about VA, VV is often where people start. I can't emphasize enough the interprofessional, multidisciplinary approach, which all of the prior studies I referenced and my prior speakers have referenced, that it does take a village. It can boil down to the number of people actually helping someone move. It doesn't necessarily require a lot in the end once you're really comfortable, but making sure all aspects are covered first and being comfortable with EM in the first place in the ICU. And then you have to consider how stable the patient is. What are their hemodynamics like? What's their gas exchange like? Is ECMO supporting them sufficiently? What are their sedation needs? Or maybe to Bernadette's point, should they not be on sedation at all from the beginning? What are their bleeding risks? So you're worried about cannulas moving and causing some bleeding from the cannulation sites. Do they need concomitant invasive mechanical ventilation? Because it may be a hindrance. If it's just a sign that they just need more support than you're providing with ECMO alone, and it's one more device to have to move simultaneously. But likewise, do they have other mechanical circulatory support devices that just aren't appropriate to mobilize? And that may be a barrier to mobilizing some of these cardiogenic shock patients. Where are the cannulae? It doesn't necessarily matter if you're comfortable, broadly speaking, with any configuration. But if you're not comfortable, then maybe prioritizing an upper body approach until you're at the point where you feel more comfortable with mobilizing femoral cannulas in the first place, and then translating that over to arterial femoral cannulas. And is the circuit stable? Is the patient stable? Are you having trouble with achieving adequate flow when you start moving the patient around and sitting them up in bed? Because you're going to potentially have only more trouble if you're getting them out of bed and walking around. So you want to make sure that the blood flow is stable, the cannulas are sufficiently secured. And finally, from your guys' perception, how necessary is it for mobilization? I would say for transplant, the standard of care. Certainly, if you're at a center that prioritizes mobilization and physical therapy as a necessity to stay on the transplant list, then it's going to be necessary for your patient on ECMO. If it's early in their course and they're particularly sick from an ARDS standpoint or cardiogenic shock, and that's not what everything's hinging on, then maybe that's not the top priority in the moment until you're really comfortable or you get a strategy where you can really have these patients awake early. And I think we encountered a lot of that trouble with COVID, where early on these patients were so sick and maybe we just didn't have enough blood flow as we were used to achieving just for non-COVID ARDS. And with more blood flow and more gas exchange support, you can get to the point where you can wake these patients up earlier, like some of the Rush experience was very successful with their strategy of getting patients awake and mobilized despite high severity of illness in COVID. And with that, I'd like to thank you for your time.
Thanks for having me. I'm going to talk about trying to get our very smallest patients moving around. And I don't have any disclosures. So we've come a long way since this picture we've seen numerous times in this meeting of the first ECMO patient to the picture on the other side here of one of our young teenage patients going for a walk outside on ECMO. And also, as Craig mentioned, when we walked our very first teenage patient as a bridge to transplant, it seemed like a really big deal. We wrote a whole bunch of papers, we described how to do this, and then numerous others have done the same. So there are a lot of instruction manuals pretty much out there of how to do this, as far as like the people you need involved, how you make sure the device is secured, all of that. And we all know the importance of getting these patients up and walking them. But when we consider how do we optimize rehabilitation and physical therapy, occupational therapy, et cetera, for our very smallest pediatric patients, we might need to think a little bit beyond ambulation and the pedal bikes that we use and our traditional strength training exercises. So neonatal and infant mobility can encompass everything from just optimal positioning, parent holding, tummy time, and seating as opportunities for mobility for them. The extent of our ability to engage our babies in these activities will be dependent on our cannulation strategy, any sternal precautions, and the patient's clinical stability. The goal is going to be for our babies to experience all of the positions just as they would if they were at home with their families, and that will help support typical musculoskeletal and cognitive and sensory motor development for them. And even for the most critically ill babies and unstable ECMO babies, we can utilize positioning to avoid secondary complications such as frogged legs, flat heads, retracted shoulders, because all of those could have lifelong implications for the babies. And when all else fails, we can just mimic the environment that the baby loves in utero, because that will make them comfortable and help us start reducing our sedation in our babies. So as everyone's mentioned, there's no universal guidelines for mobility of infant patients with ECMO or extracorporeal support, and a lot of what you can do is going to be dependent on center comfort, the tolerance of your team to do this, and preferences. So I'm often asked, how do you overcome the hurdles of discomfort and just get started? Our bigger patients, much as described by the previous speakers, are often up walking around with all different types of ECMO. But when we get down to our smallest patients, people get really uncomfortable with that. So perhaps that looks more like even just a parent holding a baby. And it could be you start with a side-lying position, move towards tummy time, and just move slowly, or using a baby seat just to get them a little bit more upright. So as everyone else mentioned, it's a team sport. You do need to collaborate with PT and OT. We also bring in Child Life to help us to yield some unique opportunities to engage our children in developmentally appropriate activities. It supports their physical conditioning, but also their neurodevelopment. And then prior to initiating any mobility plan, we always make sure that our cannulation is stable, and we follow our protocols every single time for securing all of our devices. For our non-tunneled cannulae, we take note of the depth and suture integrity. We initiate cannula stabilization, and usually with various adhesive anchoring devices and some co-band. We always take the co-band off after the mobility session, though. My wound care people would like you to do that so that you don't cause any pressure injuries. On the left of my slide, you can see that we set up a mobile PT gym in a toddler's room. And then on the right, we have a young patient that is riding a tricycle very slowly down the hallway with a team closely at her side and behind her managing all of her lines. For our pediatric patients, we really need to engage them in activities that they're actually interested in. Most of our toddlers don't want to just go for walks around the unit. And depending what's going on in the unit at the time, it can actually be really scary to have them walk around the unit. So we always try to have a destination or a fun activity to get them engaged and mobile. So if there's like a cool window you can take your patients to go look out, or a fish tank, or a mural, a playroom. And then driving these cars is a favorite activity in our pediatric units. They're cheap. We let our kids color all over them and decorate them so they get some additional sensory input. And then we have them pretend they're doing a car wash. But then for us, they're actually really easy to keep clean. So we can clean them nicely. We've used everything from bowling with plastic bins, pins and balls in the hallway, to playing soccer, playing basketball, anything that we can use to engage them. For those who aren't into sports, we can take dry erase markers to windows. So we got them out of bed, we got them to a window, and now we're drawing. And the one thing that we have also seen that's an added benefit to this beyond our patients is that when the whole team's engaging these little people at this level, it's very motivating and uplifting for everybody. And this is one of our favorite destinations, going to the helipad. So if you need to motivate a kid to get out of bed and do some walking, seeing a helicopter usually works. Sometimes it's not even about the actual physical conditioning, but just normalcy and developmentally appropriate exercises. So these patients are often hospitalized for very, very long periods of time, and maybe that kid has never been outside. So just getting the kid outside and having some sensory stimulation, letting the parents just relax in the sunshine with their kiddos. So you can start really small with your strategies. Put them in a stroller, even use their bed, and just start getting your kiddos out and about. So children can benefit from the same things their peers who are not in the hospital do as well. This picture is a picture of circle time at Duke Children's. We also have a hospital school, so it's a double benefit when you can combine educational activity with their PT or OT session. So I'm going to leave you with a short clip of my, or it'll start. See if you can find one of my patients. There he is. He's dancing. So that's my very favorite mobility activity is Duke Children's Prom. So if you want to motivate a kid longer term, if you have an end thing like that, like we need to do all these sessions, we need to practice dancing, we need to do all this to get you to be able to go to prom later. That's actually really helpful and motivating. None of this would be possible without our entire PCICU and PICU teams, but especially these people who have really championed getting all of our kiddos up and out and about. So thank you.
Get all the speakers to come up here. If you have any questions, please make your ways to the microphones. While we're waiting on that, I think these were awesome talks. This is a great session. Thank you all very, very much. One of the biggest barriers to physical therapy is often getting the patient awake. We talked sort of briefly about that. You kind of touched on it peripherally. But if you wouldn't mind, I guess, sharing your strategy on how do you approach that? The patient you have is extraordinarily deeply sedated. They're going to wake up delirious. They're going to wake up potentially agitated. From the bedside perspective, that's very, very difficult. That's very, very challenging. Is there anything you do differently in terms of medications, in terms of do you turn up the blood flow, the sweep gas flow? Do you adjust any of that to help you with that process? And then the second piece of that is how do you then get your team on board? How do you get your nurses on board? How do you get your respiratory therapists on board and everyone else to feel that this is safe and feasible?
So I think for the, breaking them down again, kind of I break down bridge to transplant, bridge to recovery, because I think there's a lot of differences in terms of how sick certain patients are. The bridge to transplant, by in their nature, we're trying not to find people who are so sick from multi-organ failure. These are people who are still really just single organ failure. It's easier for them, I think, because we go in with a strategy of cannulating and really just waking up and extubating either within hours or maybe they stay overnight until the next morning and not fall behind with tons of residual sedation. I think for the ARDS patients, we still struggle to get them awake and comfortable and minimizing sedation early. I'd like to hear maybe a little bit more about from Bernadette and Phil's strategy. But maximizing Precedex, maximizing antipsychotics, really trying to minimize benzos and opiates as much as possible. But I still feel like even our sedation strategy is a bit of a work in progress, which may be also why we don't tend to be as aggressive and successful early with mobilizing some of these severe ARDS patients. But as far as buy-in, we really have very much of an opt-out kind of policy. The assumption across the unit is everyone's doing physical therapy. And you have to give the physical therapist a reason why this patient can't do it. So that makes it, that kind of overcomes some of the barrier. The physical therapists are all in on this. They love it. I mean, they feel like this is really just, such a novel, now it's not so novel for them. But I don't feel like we have such an issue in terms of team buy-in. It's more just, kind of optimizing the patient for it, and with a pretty high bar for why you can't do it. For some of the obvious reasons, like if they're paralyzed or if they're deeply sedated or if they're just really too hemodynamically unstable.
Yeah, I mentioned it earlier. As the coordinator, I had to really kind of take on some of Phil's infectious enthusiasm for this approach because it wasn't a huge win for my team. Like I said, we kind of gravitate to that world because we like those patients that are critically ill. And although they're still critically ill, they're now being supported and they can be awake. But we do see a lot of the physiologic, the anxiety, the air hunger, et cetera. And a lot of that is just sitting there at the bedside with them, literally before we can release restraints, and just talking them through a day or two of delirium. And a lot of times I've just had to take my laptop in there, and whenever they start getting light on the sedation, like, I'm the one that's hand-holding and coaching and teaching my new specialists that this is really what it's gonna take, and it's not gonna be fun. Hopefully they do it quickly. But to see those patients be able to return to a level of function that they can go home and not have to go to a SNF is definitely worth it. So if you can tough it out for a couple, I think it'll change the culture of your program overall.
Yeah, I couldn't agree more with the comments that are being made. Really, it's just about, for me, it's gosh, you look at the physiologic, parameters, and you think, God, we can turn up the sweep and drive down our CO2, but still, you mentioned the air hungry, the part, I don't know what it is stretch receptors, whatever it is. Sometimes people actually just can't get to that point where they're satisfied physiologically, and we can't extubate them. So not that we shouldn't go there, but that's frustrating for me. To your point as well, is I think, using drugs that are less lipophilic. We know the stuff that sequesters within the circuit, and trying to teach that to, and having your team come on board to limit that sedation right from the beginning, because sometimes we're often way behind the 8 ball, because our colleagues sometimes are used to practices that we employ typically that are really ineffective in our ECMO patients. So really changing that culture, like you're saying, and the opt-out policy, I think are really critical comments that I want to just recapitulate.
Awesome.
I had an afterthought. We do use a lot of atypical antipsychotics for the air hunger, and also for our bridge to transplant patients, we've used Marinol. That has been extremely successful for the anxiety as well as stimulating their appetite. And I joke about a couple of our patients that we literally went from calorie counts to like limiting the number of bags of Reese's Pieces cups they can eat in a day. But it really has, really pushing the parameters of your normal practice has been very successful in our program. So I try to stay uncomfortably outside of the zone, and I know that the program is growing.
Cool. The only thing I would add is making sure that your team has a strategy if things don't go perfectly, because they're worried, okay, well, they may wake up, they may be agitated, they may be dangerous. This is what we're going to do when that happens, and not feeling as though they're just left, we're going, doing something crazy. Yeah, over here.
Hey, what do your physical activity guidelines look like outside of the main physical therapy session of the day? Obviously, that's where the pictures get taken, the highlights happen, but especially in the patients who are bedbound, I think in our program, it's easy to tell the nurses once the patient can sit up on the side of the bed or get out of bed to chair X amount of time per day. But the patients who are bedbound, I feel like, get the one PT session and then kind of sit. Is there homework that's given in those patients in your program for the bedside nurse or the specialist to do? And then what does that look like for the bedbound folks specifically?
So our PTs usually give exercises and goals of how often to do those exercises each day. They often write it on the window or board of the room so that they can see it, and the nurses and respiratory therapists also encourage them to okay, you've been watching TV a bit, why don't we do this? And I think that has been helpful for the patients that are stuck there.
We use a lot of exercise bands, trapeze, any of those things that can just help them independently reposition themselves initially, and then, physical therapy comes in and reevaluates them, usually a couple times a week if they're not able to get up, and just to evaluate their core strength and their progress and really work with them. We do also a lot of, charts and encouragement so that everybody that walks by can come and be their cheerleader and try to keep their attitude positive. And, a visit from Dr. Mason, it's really hard to be like a skeptic or try to lay in your bed after you get talked to from him for 30 minutes. You just want to go walk, so.
I think your point's really well taken, because, we emphasize so much physical therapy for the, bridge to transplant. Oh, they got to be active. And it amounts to 30 minutes a day, and then 23 and a half hours of the day they're sitting there potentially not doing anything. So it's really important to maximize that other time, because that's like the bare minimum. It takes a lot of resources to get the team back around again for another session. We'll mobilize them, we'll walk them, they'll sit out of bed and chair for hours and then before returning. But I think all the modalities mentioned are really very useful from a strength standpoint, upper body strength, lower body strength. You could do a cycloergometry in bed. There's different things we've done for patients who maybe couldn't get out of bed, to try to prioritize their activity.
All right, excellent. We have time for one more question.
Hi. This is probably a very rudimentary question, but if you don't have a tilt bed in your facility and you have a femoral cannula and you're still in the early stages of mobilizing, like just sitting, are you worried about kinking of the cannulas, or like what are you doing about flows and all of that?
I mean, I would say like we really have not had trouble with it. I think you have to be mindful, the length of the cannula and there tend to be the arterial reinfusion are shorter. But being mindful of not maybe like really flexing the legs so much to cause kinking. But we don't use tilt tables at all. We don't have that in our unit, and it's all about even sitting in the bed and standing and walking. And I think it's just not exaggerating things and making sure everything's really well secured. But we've been very successful. And the venous reinfusions are long, and you got even more give there, so it's even less concern in terms of dislodgement and things. But I wouldn't look at it as that you need a tilt bed. I think those are particularly specific scenarios she was referring to where they're quads and they physically cannot activate their legs. But I wouldn't look at that. And that's kind of my message to you guys from a femoral is you don't necessarily have to jump right to femoral ambulation. I think getting comfortable with other configurations and just the process and the evaluation and the team approach and different roles. But it's definitely within reach to then extend to femoral cannulation, and maybe femoral venous just to be more comfortable first before then going to femoral arterial.
And I couldn't agree more. When we looked through the data, femoral cannulation is extremely safe in terms of mobilization, in terms of complications. They're very, very few. And what we do is just test them at the bedside, get them to flex halfway, see if there's any issues with regards to flow. And remember, these are wire-enforced cannulas typically, so you're not going to typically bend them. And if you do, you're in big trouble then. But typically, it's very, very safe, actually.
I think like one of the things just to think about with femoral VA, they may not be sufficiently supported upper body from a gas exchange standpoint, so you may be in a hybrid configuration, VAV. It just adds complexity to the patients. That might be as much a motivation for some centers to reconfigure to upper body just to minimize the number of cannulas and potential issues in terms of flow and splits. But that's also feasible. Part of it just depends like what's your priority and is the current configuration achieving all of that, including support. And back to your question originally, maximizing the blood flow is probably a major contributor to being able to wake someone up and dealing with whatever surges in blood pressure and everything that they then encounter.
Great, and thank you guys for your engagement. I want to encourage everyone to go next door to the closing, or 2 doors down, I guess, to the closing remarks. They're going to have a conversation with Dr. Bartlett talking about the last 50 years of ECMO, so it should be a real treat.